So when we talk about glucose sensors, you will see these children wear two sites, one for the pump to deliver the insulin, another site for the glucose sensor. So in future it could become one site. So right now if you see two sites, there's a good chance this child is wearing a glucose sensor. And if the child is wearing glucose sensor, it might give you wonderful information because it measures blood sugars every 5 minutes and the reading will come on the screen as a graph. So you can actually go back up to 24 hours to look at how the blood sugar pattern was there for this particular patient. These numbers are less. Not many children have glucose sensors, and even the ones who have glucose sensor don't wear it on a regular basis. So just keep in mind, if you see that, that's the information, and we can actually download it and look at these numbers, and that's how the fluctuations will look like. Each color indicates a particular day, and this is the timing. So it's more like the Holter monitoring you do or EEG. You can actually look at the pattern of blood sugars, except that you don't have to know the complicated ways of reading EKGs and EEGs. I cannot read them, but this one is up is high number, low is low number. Diabetes management is always very simple, as you all know. Okay, guidelines. Guidelines for hemoglobin A1C is a little different for pediatrics versus adults. In pediatrics, we have different levels of hemoglobin A1C as good control according to American Diabetes Association, because of age variations result in hypoglycemia a lot more. So for children less than 6 years, our good hemoglobin A1C is 8.5% or less. In children between 6 to 12 is 8% or less. In children between 12 and 17, it's 7.5% or less. And after that, you have the same adult cutoff, which is either 6.5 or 7%, depending on which guideline you use. So younger the child, slightly higher hemoglobin A1Cs are okay. You can get better hemoglobin A1Cs provided there are no hypoglycemic episodes. Okay, so typically we have this range of 6.5 to 8.5%. However, the average for our practice at this point of time, thanks to all the adolescents, is pretty high. It's at 8.9%. We are working on our adolescents to become a little bit better. So our guidelines, we have none. So unlike what you see in adults, we don't have guidelines because we custom design the guidelines on where we want the child to be based on that particular child and the social circumstances the child is in. For example, child is in foster care. There's nobody else to supervise the child. The child doesn't really take care of her or his blood sugar. Then we'll be checking a couple of times a day with mixed insulins like 70-30 or 75-35. On the other hand, you have robust family, excellent support, family is very involved, they'll be wearing glucose sensors and insulin pumps. So the other thing to understand is just because they are on insulin pump doesn't mean they are in good control, because sometimes they'll start off well and then they go down the lane, down the drain over a period of time. You should understand my English is not my mother tongue, okay? So I'll slip here and there, so bear with me. Okay, team. The reason our program is more successful than anybody else is because we have a great team, and I do very little. My team does most of the work. I just do all this public relation work like what I'm doing right now. Okay, so going back to story, God then said, I have sent you healthy vegetables, hearty healthy vegetables and olive oil in which to cook them. And Saturn brought forth deep fried shrimp and catfish and chicken fried steak, so big it needed its own platter. And man gained more weight and his cholesterol went up the roof. Okay, so what do we do when the child comes to the ER? So the key thing to identify is whether the child is sick or not sick. If the child is sick, it's straightforward. The child has diabetic ketoacidosis. We need to manage right away. Most of the management is just like adults, except that we don't give bolus insulin. If there's one take-home message for today, please don't give bolus insulin. You don't have to pump in 5 units of insulin as soon as the child walks into the hospital. we only correct insulin blood sugars over a period of time, because as you know, risk of cerebral edema bringing down the sugars very fast is a lot higher, and in children we really don't know the sensitivity of insulin. In younger children, usually they are very much more sensitive than adults, older children, and children who have had diabetes already, who don't do a good job, could be very resistant to insulin. So as a default, we always start with lower insulin dosing, and especially in younger children we are even more cautious, because there's no rush to bring down their blood sugar. Blood sugars can come down over a 24-hour period. So take home message: no bolus of insulin, number one. Number two, the infusion rate is slightly different. In adults you use 0.1 unit per kilo per hour. In children we might use half or quarter of this dose, so it will be 0.025 units or 0.05 units per kilo per hour, and then we can slowly increase it. Usually what I do is I put in a sliding scale where we check the blood sugar every 1 hour, and we try to titrate the blood sugar to fall down between 50 to 100 milligrams per hour. So that will be the goal, number one. Number two, bolus fluid. We bolus at about 10 ml an hour, normal saline. Now, if the child is very dehydrated, has a circulatory collapse, the child is really sick, you want to bump in more fluid, yes, you can give multiple boluses. You can do 20 per kilo. Rarely we can use bicarb as well if the child is so acidotic and has a circulatory collapse. There's no circulatory collapse, we never give bicarb. Just to put it in perspective, the last 12 years maybe I have used bicarb once. That's how rare the use of bicarb is. And same thing, using more than 20 per kilo bolus is extremely rare. So if you're thinking of a large amount of fluid bolus, think of my statement again. We see a whole bunch of children and we don't do it, and things seems to be working out fine, so something we do is seem to be right. So slow correction on fluids, so slow correction on blood sugars. Now, no bicarb. If you really think we need to bicarb, let's talk to the ICU guys before we decide on that. Then we always look at the renal panel. You don't need to do a serum acetone. If you do a serum acetone, it's okay. It's not going to give any more information than the CO2 you're going to do in your renal panel. So CO2 being low, typically if it is less than 15 in a child, we take it seriously. Now, occasionally you will come across a child coming to the hospital either with a low number or a high number, and you do a renal panel. Renal panel shows the BUN and creatinine is normal, the CO2 is normal, the blood sugar is in a good range. Why did they show up in the hospital? Because the child cannot hold fluids. If the child cannot hold fluids, that's a good enough reason for them to be in the ER and to be in the hospital. Because if they go back home, they'll come back to you again. Unlike in adults, they don't have too much of reserve available. So if the child is not drinking fluids, we need to do something about it. Why can't we just give Zofran and leave the child at home? That's because we don't know whether we are missing an appendicitis or an intussusception. Those things can happen in children too. Just because they have diabetes, it doesn't mean they cannot have anything else. So sometimes you will see children coming to the ER not in DKA, but will need your help with fluids and stopping of vomiting and so on and so forth. So keep that in mind. Rarely you will have a hypoglycemic child coming to the ER. By the time they arrive, usually they are well, because most of them have glucagon at home and they would have given a dose of glucagon. The dosing, just for you to remember, is 0.5 milligrams intramuscular or subcutaneous in children less than 6 years. More than 6 years is 1 milligram. There's calculations, you don't have to remember all those things. So either half or 1 milligram, depending on whether the child is less than 6 or more than 6. Now,